So we have our next speaker is Dr. Namrata Sharma herself. She's the Iron Lady of Ophthalmology in India, and she's going to be speaking on intraoperative OCT guided cataract and refractive surgeries. And again, a very interesting topic, and she has done tremendous work on this area. So, Dr. Namrata, please go ahead.
So thank you, Gaurav, and thank you for always helping out with all the sessions and all the programs that we do uh, on the AIVerse platform. I would be talking to you about IOCT guided cataract and refractive surgeries, and this is actually the first video to show how IOCT may help in cases of cataract surgery. I don't say it is required. Perhaps it's not required. It is just we are trying to find its uses. For instance, when you make a side port, you can actually see where the side port at, which you can see otherwise also. And then when you make a uniplanar or biplanar incision, you can actually appreciate it on the intraop OCT microscope. Then again, when you initiate the capsulorhexis, the flap of the capsule can be seen, and probably in cases which have clear corneas, it really doesn't make too much of a difference. But in hazy corneas, it helps you to see underneath that haze. And in case you do lose your rhexis underneath the haze which is present, one can grasp it again. Then when you're doing hydro procedures, you can actually see the separation when as the wave of the fluid wave goes between the capsule and the cortex, one can see it. And then again, when you do hydro delineation, one can see the maceration of the cortex which occurs. Then when you're actually chopping and you're making a crater, then by looking at the side, one can make out the depth of the crater. And just notice how the whole thing bulges up. And when you put the viscoelastic, then the whole complex, the posterior capsule cortical complex, comes down. So this is just to show the posterior capsule bulge and how it actually goes down. And then whenever all the intact PCs can also be seen, not that again you need to see it, but sometimes you may, especially when it's a complicated case. Again, when you are doing the intraocular lens insertion, then one can see it going. And there is this distance which can be measured between the IOL and the posterior capsule. And when you actually do viscoelastic aspiration, you can see that this gap actually decreases. So it helps you to know, and sometimes the capsule and the lens are quite stuck to each other. So you know that the entire viscoelastic is out. Then as you do the wound hydration, sometimes there are these small wound site DMDs which are not visible, but they are visible if you have an intraop OCT microscope. And if they are there, then one can address them easily at that point in time. Whenever you do this hydration, the spindle of hydration is seen. And notice as you do wound hydration, the iris drops down, and there is this small DMD which is present at the wound site, which can be seen, and it can be addressed by injecting air bubble and seeing that the DMD is attached. Of course, most of the DMDs, this is the port side DMD, most of the DMDs which are there do resolve over a period of 1 week, and you actually do not need to do anything about them. Then there are some other different situations. For instance, this posterior subcapsular cataract can be seen, and there is a distinct gap which is present between the PC and the overlying cataract, and then you can differentiate this. This becomes especially useful when you have a posterior polar cataract such as this, where you can make out that the PC is also involved. In white cataracts, it has a special role to play. So you have these black areas, which means that the fluid clefts are there. And so once the fluid clefts are there and you give a nick in the overlying capsule, then in those cases, you actually know that the fluid is not going to come out. But, and again, this capsular excess margin, which is everted, can be seen. Of course, it can also be seen by the staining of it, but it just enhances your visualization still further. Now, after doing this capsular excess, now if there are white cataracts which do not have fluid clefts at all, and they are, it's just absolutely like this, then you know that as soon as you give a nick in the overlying capsule, the fluid is going to come out. And this ejection of the fluid can also be highlighted on this. The liquefied cortex can be seen. And then you know that when you have a picture like this, what you have to do. Now, this is a case of a capsular distension syndrome, and there is capsular phimosis. There is increased lentricular capsular gap. So, in this case, this phimotic part was removed. And as soon as we removed the phimotic part and did some amount of aspiration, notice how now the IOL is sticking to the back of the posterior capsule. The phimotic part is out, and then you know that there will not be any myopia, which was there in this case prior to the surgery and in the post-op period. So these are the situations in which it helps in cataract surgeries. There are several more, but for the want of the time, I did not put it. And then there are certain situations in refractive surgery also. For instance, in this case, perhaps it is not required and maybe you can do it otherwise also, but especially if there are beginners who do a lot of needling when taking out this lenticule, intrastomal lenticule, then it may become a little difficult. So this MIOCT gives you the feedback on how the entry can be done. Now here the incision is being opened and entry is being done anterior to the lenticule, so you can make it out on the IOCT picture. And then when you've gone posteriorly, then again adhesions which are there can be released with the help of the dissector. And when you do create false planes, these are easily identified. And when you go posteriorly, again, you can make out on the intraop OCT that now you are posterior. Then once your lenticule is out, one can just take it out and this is just put onto the surface. And then one can scan the entire area of the interface to see that there are no remnants present. In couple of cases, there were lenticules present and we have shifted the patient to the IOCT and have taken this out and also published the results of the same without actually having to call the patient on another date. Now, this is a case in which the phakic IOL is being inserted. And again, like I said, the dynamics of the incision can be studied. But I think more important in these cases is that when you insert the IOL, the phakic IOL, then you can actually make out, number one, where your haptics are tucked in, which you can make out otherwise also. But sometimes when the dilatation is limbus to limbus, then it becomes difficult. So you can make it out, and more importantly, you can measure the wall between the phakic IOL and the crystalline lens, and then aspirate out the viscoelastic. This is the wall that is there, and there is a scale which is present on the adjacent side, which helps you to know how much the vault is, and you can recalibrate it by using the magnification factor. Now, once the viscoelastic is out, then again you can measure and see what the vault is at the end of the surgery. So you will not leave very high vaults or very low vaults intraoperatively at least, and then these can be monitored post-operatively also. Now, this is just to show it does make a lot of difference, especially for complicated cases. If there are glued IOLs which you are doing, you can actually make out the depth at which your pocket is being created. Sometimes when it is too deep or it is too superficial, again, you can make out. And when you're making a tunnel, you can actually see the area of the tunnel here where the tunnel is being made. So it does help in those cases, especially when putting the IOLs. Now, I will not go into the detail for the want of the time, but when you do tuck it, you can make out the level at which the haptic is there. And again, in complicated cases, we've used it, especially when there have been extrusions or when there have been, when the conjunctival, when there's been a, when one can see the edge of the haptic from the conjunctival side. So this is just to show that vertically positioned extruded haptics is there. This was there in one case, and then this was taken up, a tunnel was created, and this was then placed inside the tunnel, which again can be seen here. So one can be absolutely certain that you are there in the correct plane and you have tucked the haptic in the correct position. So thank you very much for your kind attention, and not saying it is required, but I know that it is here to stay, and we will keep modifying. There will be modifications in the technique, the way we do it, and also in the technology further. Thank you very much for your attention.